Welcome to the We'll Keep It Short podcast, and we're your hosts. I'm Dana Ukwama. I'm a pediatrician. I'm currently in my second year as an attending.
And I'm Diane Ukwama. I'm a child and adult psychiatrist.
And the purpose of our podcast basically is just to share our medical expertise, debunk medical myths, and just give our personal insight into our own medical journeys and experiences.
Yes, and today we have a guest sitting with us, Dr. Khadijah Williams, obstetrician and gynecologist, and just a little bit about her background. So she graduated from the University of North Carolina, Chapel Hill, and she just completed residency at the Johns Hopkins Hospital. Congrats.
Yes, congratulations.
Thank you.
You're welcome. You want to share what you're doing next with our viewers?
Yeah. So after residency, I'll start fellowship in maternal fetal medicine. Essentially, I will be managing high-risk pregnancies.
It's amazing.
Congratulations.
I feel like that ties so well into what we're speaking about today.
Yes.
Because I feel like it's such a taboo topic in medicine to talk about family planning and things like that later on. But you hear so many women nowadays saying that they're either leaving training to have a baby or pushing off their training to have a baby. Do you guys want to comment on the impact that medical training has had on family planning in general? Is that something that you had to think about at all?
Yeah. We'll start with you. Is that something that you considered when choosing a specialty or just in general?
It was. Well, when I finished medical school or during medical school, and I was thinking about what specialty I wanted to go into, initially I wanted to do trauma surgery. And then at some point realized that, I really wanted to know my patients, have a relationship with them. And I thought OBGYN residency would be a little bit not easier, but it wouldn't be as demanding. And boy, was I wrong. But I got pregnant at the beginning of my third year of residency. And I will say we didn't plan for it in the traditional way. It was one of those things where me and my husband were like, oh, well, you're going to be a dad. And we had to, figure things out, which we can talk about. But I do think like my program has been supportive, and like my family, everyone's been supportive along this journey. So, but it has been very challenging to have a baby like in residency.
Yeah, no, I definitely understand that as well. I think that's what a lot of young women think about. Like you said, choosing a specialty that will allow for that. You can kind of think about it. Like for me, I chose primary care. Not so much thinking, I loved kids. I would pick it anyways, but I kind of was thinking, will this allow for me to have that experience later on and let it be not easier but more manageable at that time as well.
And I think with psychiatry, I love psychiatry just like you love peds, and same with you and OB-GYN, but it definitely like gives that lifestyle that I think would allow me to be more at home and present for my future children.
But you said your program was very supportive of you, right? Because I know you OBs like work endless hours.
Yes.
What was that like?
So, we work 24-hour shifts. I'm not sure if you guys do that as well.
We did in residency. Yeah.
Okay, perfect. So, those 24-hour shifts were hard, especially on labor and delivery, because we were up running around that entire time. But I did not tell my program until I was 16 weeks pregnant, and I was literally about to pass out in the OR when I went to triage, and my name popped up on the board there, and that's how my program found out I was pregnant, because it popped up on the labor.
My goodness.
I know, so it was surprise, and my program director was the attending on that day.
Really?
And she was she came in, she said, I was like, yes, I am pregnant. And she honestly gave me the biggest hug. She said, things are going to be fine. We'll work through it. But it's just shuffling around your schedules. And it was just a big transition, because you're in the OR so much. So asking people if you can sit down, have water, take a break. And I was very nauseous during that time. And so I would step out and be sick for hours in the OR. So, and it was so challenging, but ultimately they understood. Ultimately, we knew it was going to be fine. But
how does it work? Oh, I'm sorry. How does that work with time off and things like that when you're going to your appointments and everything like that?
Luckily, my OBGYN was my mentor, basically my attendant.
Good.
So many of my appointments were on labor and delivery. I would just go into a triage room. I knew all the questions she was going to ask me. I was like, nope, I don't have this. Here's my blood pressure. It was a 5-minute appointment. But they also gave me time on Wednesdays to go and see Dr. Thomas. So it was good.
They were really supportive.
They were supportive. And I took 6 weeks off for maternity leave, which in hindsight is nowhere near enough.
I was just going to ask you, is that?
No. No, 6 weeks is such a short period of time. I mean, he was still like a little baby. And I, went back to work and I was like, this is so hard to do. And then I was trying to breastfeed, and I think I could have been successful, but it's a job
Yeah,
to
it's a
breastfeed.
true job.
Yeah,
It's a job.
That is,
Right.
it's true.
Yes,
That's true.
it's a job. And I said, you know what, this isn't working for me. And I went through this period where I said, am I a failure for not breastfeeding? And here at Hopkins, it's like, oh, we're, I don't know the exact language that they call it, but they say we're a breastfed, like, they promote breastfeeding,
Yeah.
right, on labor and delivery. And I said, ultimately, a fed baby is a happy
Fed
baby.
is best. We say that in pediatrics
Yeah,
all
really?
the time. Yeah, fed is best.
Perfect, because it takes away the stigma that a lot of women
Exactly.
have when they feel like they cannot breastfeed. And I said, you know what? As long as my baby is fed
Healthy.
and healthy, and then I was going to work at night, so I could not have an exclusively breastfed baby because my schedule was too
it was too tight.
too
A lot.
tight.
Yeah, exactly.
So, but they understood, and we ultimately worked it out.
Now you have me thinking. I'm sure you have friends in other careers. Like,
yes.
and you took 6 weeks away from residency, right? Does that sound in line with what people? Because I really have no idea what people in other line of work like. No. Can you speak about that a little bit?
Yeah. So, I have friends who are in finance or accounting or just like business, and typically they take between 8 to 16 weeks. 8 weeks is usually like the minimum. 12 weeks is usually the average. And so, with me only taking 6 weeks, I was like, wow, this seems so unfair in a way, right? Or I honestly felt more like a failure because I was not at home with him. And having to go back to work and having to go back to training. And when I talk to other people, they're like, yeah, 12 weeks was nowhere near enough. And when I talk to the nurses on labor and delivery, they typically take 12 to 16 weeks. And, I in my opinion, I think at least 3 months you should be at home.
That's true. You need that time to bond with the baby early on too.
You do.
I'm sure that can play with like mental health for women or families coming in as well. Especially people that moms to come to my clinic as well. It's tough.
It's so hard.
It seems tough is what I say, since I'm not a mom, but it seems very tough. Overall. But
if you wanted more time, would that extend your training? Like if you were like, I need like 10 weeks.
Yeah, so I could have taken more time. And actually, I still have to do a couple of makeup days in residency. In my mind, I'm like, listen, girl, I graduated on Friday. I say I am just here so I don't get fined in the next couple of days. But it would have, I would have had to extend. But I also got the flu when I was 8 months pregnant. And then I got COVID 10 weeks postpartum. So I had to take off 2 additional weeks. So that's why I have to make up days.
Got it.
And so, in hindsight, would I have taken that time? I don't know, because I don't know if it would have made that much of a difference. I don't know if those 2 weeks would have made that much of a difference, because I still had that postpartum depression and anxiety that most people don't talk that much about.
Yeah. And I imagine if they made you more comfortable and were more agreeable to some of the things, like having more time off, maybe it would be less likely to precipitate mood changes, like anxiety and depression. Maybe I'm wrong. I'm not sure. But I feel like with medicine, maybe they're not as accommodating to mothers all the time. I don't know. Do you agree with that? Or is that fair to say? Okay.
I do agree. And I think residency is just, and I'm sure you guys know, it's just a different experience.
Yeah.
Right?
Yeah.
And, we work so hard. And just, I know people in other careers work really hard too, but I wasn't sure initially if I had postpartum depression and anxiety, or if I was just sleep deprived, or if I was just like a resident and going through the motions. And I do think for women of color, there isn't that much emphasis or discussion on what postpartum depression and anxiety, particularly postpartum anxiety, because I didn't so much have depression. I was anxious all the time.
Sure. How did that manifest into your work and day to day?
Yeah, so I think I, started to perseverate on maybe things that didn't go that well that day at work, or if other people thought that I was juggling too much as a mom, or maybe her surgical skills aren't up to par compared to her co-residents. Or when I would leave and do a 24-hour shift, I would just, or even just a 10 or 8 or 10-hour shift, I was just anxious about my kid not or I don't know, feeling that I wasn't present.
Got it. Like,
Or
was
I
it a
was
sense of guilt? Is that what you
right.
mean?
It was
Got it.
mom guilt,
Got it.
and sometimes mom guilt. People don't know that mom guilt is actually a form of anxiety or
Yeah.
depression
Yeah, yeah,
sometimes, right?
yeah,
It's
yeah,
because everyone says, "Well, we all have mom guilt," and I'm like, "Yeah, that's true, but how does that manifest in your
yeah,
day to day?"
yeah. How is
So
that
it's
different
hard.
from new dads that you've worked
Oh,
with?
that is yes. And it's interesting that you say that because at Hopkins, our director of labor and delivery is actually a black man. His name
Really?
is Jason Vaught, Dr. Vaught. And we were talking actually a couple weeks back because we had a mom who had a very traumatic experience who was airlifted to Hopkins from an outside hospital, and she had like a history. She had a C-section, and then ended up having a hysterectomy with us, and she was very close to death actually. And so she ended up doing fine, and the dad came up to us and said, are there any resources for black men or just for dads postpartum? And we said, actually, no, not that many.
We speak about moms a lot more.
We
Yeah,
talk
we
about
speak
moms
about
a
that.
lot
Yeah.
more. And I, got to thinking, I said, even when I had the flu, when I was 8 months pregnant, I just walked into triage and basically collapsed. My heart rate was in like the 140s. I could not breathe. Luckily, I knew all the nurses. Like, I could just swipe my badge into triage. I knew the nurses, and they were like, wait, something is really wrong here. And I got help immediately. But like, if I did not have these resources, like, what have this looked like? And my husband was like beyond himself because he is not in medicine at all. He's like, I don't want anything to do with that. But he was so anxious, and he actually was very depressed for some time because he was like, I feel like I am helpless in this moment. And so I do think we need more resources for dads to talk about what this looks like for them. And I don't know how this can be structured, but I do think that would be a good idea.
Yeah, I agree with that 100%.
Oh, we could speak for so long about that.
Yeah,
I have
exactly.
so much brewing
especially
about.
for you, for psychiatry and the standpoint from that as well too. But you are speaking about something else, like the things that you experienced during your own pregnancy. You were sick with the flu. You were sick with COVID. And I just want to go into things that people like of color may experience as well, like as they are pregnant. But the first thing I want to touch on before that is advanced maternal age.
Sure.
Like what exactly that is and what kind of complications that can go into for pregnancy.
Yeah.
Can you speak about that?
Sure. So advanced maternal age is what we define as a maternal's age of 35 years or older at the time of delivery. And so advanced maternal age is I would say, evolving topic or subject, because before this idea of advanced maternal age, there was geriatric pregnancy, which no one wants to see in their chart, right? Like geriatric pregnancy, what does that mean? So now we've moved to advanced maternal age, and that's important for people to realize, because once you hit 35, you're at increased risk of things like C-sections, preeclampsia, right? Cardiovascular diseases, you're at increased risk of blood clots. The things that women who are younger than 35, of course, they're still at that increased risk in pregnancy, but once you hit that threshold, you're now at that increased risk. And really, that age of 35 was chosen based on the declining rate of fertility after age 35. So then sometimes those women are at increased risk of having IVF pregnancies, and we know IVF pregnancies come with increased risk of preeclampsia, twins, and a different host of other complications. But we are actually seeing more advanced maternal ages now because people are delaying childbearing until after careers or later on.
I have a lot of good questions about this, but first, can you explain to our viewers what preeclampsia is, just in case?
So preeclampsia is high blood pressure in pregnancy. It typically manifests after the 20 weeks, right? So there are different forms of preeclampsia. And so when I explain it to our patients, is that preeclampsia is on a spectrum, because you have preeclampsia without severe features, with severe features, preeclampsia that could be superimposed, meaning if you had chronic hypertension prior to pregnancy, now that you're in pregnancy, now you're become more protein in the urine, or your blood pressures are becoming more uncontrolled, or you're becoming more symptomatic. And then you get on the spectrum of eeclampsia, which is seizures in pregnancy due to preeclampsia. So it's on a spectrum. Yeah.
Thank you.
Yeah.
Would you say that like for advanced maternal age in general, I'm like even when I'm newborn rounding and I see a
Mhm.
lot of moms that are like now 35, 36,
Mhm.
40, 41, and when I take care of their babies, they are healthy. You know, they're healthy. I don't see
Sure.
any
Uh-huh.
issues with development
Yeah.
later on.
Mhm.
Do you think that like that cutoff of 35 is still as strict as it used to be? Like are you seeing that like more and more women are pushing on past that age and still delivering without any like complications?
Yeah.
Is it
Yep.
still appropriate that 35 geriatric advanced maternal age number?
Yes.
Yeah.
So there are women who go past 35 and
Yeah.
do just fine, right?
Okay.
Yeah.
And it always somewhat depends on your health prior to pregnancy.
Got it.
Okay.
So I tell people all the time, especially if you're in, more mature age group, is that make sure you have a primary care doctor, right? Make sure you have someone who is just looking after you annually. And then when you are ready to have a kid, you can start having those preconception appointments, or they can get you connected with a maternal fetal health specialist that you can go to, say if you have a history of chronic hypertension or lupus or any other like autoimmune disorder, that you may need to see someone sooner rather than later who can follow you throughout your pregnancy.
Okay.
Because what you don't want is to, get pregnant and then you are in the second trimester, third trimester, and these things pop up, and then you have no resources or nowhere to go, or now you find yourself um, uh, with a provider, although hopefully really good intentions, where it's outside of their scope of practice.
Yeah.
you know?
Yeah. I know I speak to my patients a lot as well as about like how advanced maternal age as you get older, there is a risk for neurodevelopmental disorders such as like autism, like autism spectrum disorder, or maybe like genetic disorders like Down syndrome.
Or the other trisomies as well.
Exactly. So,
is there like a certain prenatal counseling that goes on at those appointments when you know a woman has reached 35, certain testing that you offer at that time too?
So we typically do cell-free DNA, which is just a blood test looking for those trisomies, right? And so previously you had like your first trimester screen, and we still recommend that too, where that's blood draw and the ultrasound, and then previously you had your integrated genetic screening or your sequential, but really we move more towards that cell-free DNA.
Got it.
Because it has a better detection rate with your trisomy. So we always talk to everybody about that, but particularly our moms who are advanced age. We say, hey, this is something you may want to consider. Now, granted, you may have women who say, I don't want to know, right? I don't want it. It doesn't matter. I don't want to know, and that's okay too. But at least we want to make sure that option is there for them.
True.
Yeah, completely.
Is amniocentesis still something that's offered, or is that?
Yep. So when you think about your genetic screenings, you have your or your genetic testing, I should say. You have your screening and then your diagnostics.
Got it.
So your screenings are like your cell-free DNA, and if they're concerning for a trisomy or any abnormalities, then you can go into like your amniocentesis.
Got it.
We don't do them in residency. We more so do them in fellowship. So I don't know how frequently they're still being done, but it is something we still do at Hopkins.
Got it.
Yeah. One of the things we had a question about, a lot of our viewers asked us about a higher risk of complications for women of color, African American women during pregnancy. Can you speak about that? Or should African American women or women of color be more worried as they prepare themselves for pregnancy when it comes to these complications like preeclampsia and things like that?
I would say should they be more worried? I would say they should be more informed. Because
I like that.
I don't want to, and I try not to scare, like, especially our moms of color, because they're like, oh, this is going to happen. And then, but it is something that, you should be aware of. That as you get older, you are a woman of color, you are at increased risk of like the preeclampsias, blood clots, infection, sepsis, C-sections, right? And some of that may do with pre-existing conditions, but some of that is just due to racism.
That's what I was going to say. It's more so due to the comorbidities or racial bias that they face when they get into these hospitals.
Right.
Do you speak to your patients about how to advocate for themselves when they're in those positions?
Yes. So, I tell my patients, really just speak up. If you don't feel like something is normal for your body, that's okay. Say something about it. And I know sometimes in medicine, and I found myself doing this too, it's like, oh, that's normal, right? That's normal. And then while that may be normal in pregnancy, that's not normal for her.
Exactly.
That's not normal for her body.
Exactly.
It's so important.
So that must, we must keep that in mind as well. And so I say, listen, here's, if you're feeling this, here's how you should bring it up. And I think sometimes women get labeled as angry or
Yeah.
difficult patients, right?
Sure. Yeah.
And so, I try not to tell our patients to mind your tone, because that, for me, that's not a thing. But you just have to come out and say, listen, I don't feel well. Here are my concerns. And when you go to your doctor's appointments, have a list of your questions or concerns.
Mhm.
And if you don't feel comfortable giving it to the doctor in that moment, give it to your MA, or the nurse, and maybe she can slide it to the doctor earlier on.
Yeah. Yeah.
Yeah.
I watched this one TikTok and it said that women of color, even if they have great jobs, they're earning a lot of money, they're
Yeah.
married, they've been pregnant before, they're still at risk for like the bias that we're speaking about.
That's right.
What are your thoughts on that?
And that is very true.
Yeah.
And even when I was pregnant, I said, well, thank God I am in a hospital where I work. So everyone, even down to the nurses, the MAs, they're all my friends.
So you had this fear as well, you being like educated, you're OB-GYN yourself.
Yes, I did. And, I was so nervous throughout pregnancy because, you just know, you just know too much.
Right. Yes.
And I was like ultrasounding myself every day. I had the Dopplers. I'm doing kick counts, seeing, okay, is baby moving enough, right? But it was a fear that I had even as, a healthcare provider. But I think, the most important part is just recognizing that these biases are out there. And even if you are educated, even if you are at a certain income level, sometimes I think we use that as a cloak almost, right? That I have made it to this status, and that means while I've made it out of, certain environments or whatnot, you're still,
just as much at risk.
Exactly.
You know what
exactly. I mean? And so that must be kept in mind as well. And I tell patients, if you can, if you're interested, find a provider who looks like you, right? Get a doula. No matter if your income level, get a doula. Get someone if you cannot speak for yourself, or if you don't know how to speak up, there's someone there present with you.
Yeah.
I've heard a lot of women of color say that they are no longer interested in delivering inside of a hospital. Like, can you speak on that a little bit?
Yes. I want people to be able to deliver in whatever way that they feel comfortable. I have patients come to me and say, I want to do a home birth. And I'm like, that's great. But here are the risks of home births. We've seen some devastating outcomes due to home birth. So we've also seen devastating outcomes in the hospital.
Exactly.
That's true. Right?
Yeah.
As at one point I thought about having a home birth. I said, well, I'm going to walk around my house and get in the shower and do all the things.
Exactly.
Ultimately, that was just not my calling. But, I think that has to be an informed discussion with the patient and their provider, right? Thinking about what comorbidities do they have? Are they at increased risk for things like hypertension, preeclampsia? Do they have a bigger baby? Because then we start thinking about shoulder dystocias.
Yeah.
And the most devastating outcome that I've seen is someone who had a healthy pregnancy, healthy labor, but while at home, the baby's shoulders got stuck. And she had a midwife. The midwife who was there was unable to do the maneuvers, not because of lack of skill, but because you have to move the bed a certain way. You have to move the patient a certain way. You need stools, and you need people in the room who can help relieve that shoulder dystocia, right?
Yeah.
And, unfortunately, the baby died because once the shoulders get stuck, blood flow isn't going to baby anymore. So, or, baby comes out. We've seen where someone had a massive postpartum hemorrhage and a mom has passed away at home. So all of these things must be kept in mind.
Yeah.
And then once you have that discussion with your provider and you find that this is best for you, then great.
Yeah.
But I don't think it was something that once I really thought about it, I said, I don't know if this is something I'm really interested in.
So what would you tell like a close family member, or like a little sister, if they said home birth or should I go to the hospital? Or is it case by case?
It's case by case.
Okay.
I would probably tell my sister or cousin to not do a home birth.
Okay.
But I am not against them. I just think I have only seen what I like, the experiences that I have.
Yeah.
While there are many, midwives out there who are trained, right? Who I trust. I know midwives who are really good. But for me personally, I don't know if that would be my recommendation.
Okay.
But more so, I think I would want to ask, why do you want to do a home birth?
That's an important question.
That's a good question too.
Yeah.
Because I'm wondering if, like, even for you, were you thinking about it because like you didn't want to deal with, or you were nervous about like the treatment you were going to get in the hospital? Is that why you were thinking about it, or?
I think I wanted to. That's a really good question. I think I wanted somewhat of a different
Got
experience
it. Sure.
because even in the hospital, we hook people up to IVs. They have an IV almost in both arms sometimes, or just one arm. They have the belts around their belly. Like, you're a little bit more restricted in the hospital. We put people on a clear liquid diet. And if you have a mom who's been in labor for 10, 15 hours and then it's time to push, it's like, well, what energy?
Yeah.
She is
Yeah.
exhausted,
Right.
right?
Exactly.
And so I said, well, I want to walk around and I want to get in the shower and I want to have this almost like earthside experience.
Sure.
And I think ultimately my water broke at home like around 3:45 in the morning.
Mm.
And I said, oh, I guess this is that. And I, woke up Nigel. I took a shower. And by the time I got in the shower, those contractions hit me like a ton of bricks.
Oh, wow.
And I said, oh, this is not what I was not ready for this.
Sure.
So by the time I got to the hospital just to make sure things were okay, I was like, I need an epidural. Like, this is hard
Yep.
for
So
me.
you have to get to the hospital. Does the
Exactly.
baby get the same things at home though? Are you guys still doing like the vitamin K, erythromycin, all that? Do you still get that at home?
I think so,
Okay,
but
just making sure.
actually, I don't know.
Yeah, I mean, I wasn't sure. I just wanted to check with you
Yeah,
too.
that's a good question. But I think there's a different protocol for babies who are delivered at home. I don't know how soon they have to be seen in the clinic
Got it. Okay.
versus like hospital, because if they don't give vitamin K and
Yeah, that's the thing I was thinking. I was like a little unsure about that. That's why. And then I also wanted to make a distinction. The doula and midwife, is that the same?
Mm-mm.
Okay.
No, so a doula is an individual who has gone through courses, who has been certified for a doula. Midwifery school is very different, so there are two different tracks. I think the midwifery school is a little bit more requires a little bit more education, and they're allowed to deliver babies. They're allowed to manage, pregnancies, versus a doula is more so just a support person, not just a support person, but a doula is a support person for that patient.
And then before we get into egg freezing, which is our last topic, I do want to ask one more question. I'm going to pose this very briefly to you and Khadijah.
Yeah.
I'm sure that like mothers come to you and especially like in cold and flu season, speak about maybe worries about like the COVID-19 vaccination, the flu vaccine, and they may be hesitant because they think it's going to hurt the baby. What would you say to mothers who come in with those concerns?
I advocate for all vaccines. Just as a pediatrician, I advocate for everything. I always give them the potential, like the benefits of getting the vaccine. Well, I don't speak to the mothers directly, of course, but giving the vaccine to the mother will give protection to the baby for the first few months of life as well. I tell them about the side effects that we know of the immunizations, including like, flu-like symptoms, fever symptoms in the first 24 hours or so. But I always say that the benefit outweighs the harm that there may be, especially if you get the chance to give protection to your baby, then why not? So that's a big thing for me. So I'm for vaccines as a pediatrician.
Same.
Same. Okay.
Yes.
Yeah. Do you get mothers who come in and ask those questions, or do you tell them to go to the pediatrician?
No, we get mothers too, because we recommend COVID vaccine in pregnancy. We recommend the flu vaccine, the RSV vaccine, depending on the time of the year. So we recommend those, and typically people are receptive of them, right?
Good.
But then you have your people who are like, no, just like Rogam. There are people who like refuse to give Rogam, right? And so I tell people, listen, all I can do is give you the data. And it's shared decision making. It doesn't change any way how I am going to care for you or your baby.
No, it doesn't.
But I can only give you my recommendations, right?
Yeah.
And I feel like if you just show that you're being open with them and they don't feel like you're like pushing them, they're way more open to listening to you and responding well to it. And even if you don't get a yes from them, maybe in the future you'll get a yes just because you gave them such good like rapport and conversation.
Yeah, and I imagine letting them know that we all want the same thing, like a healthy baby. We all want
Exactly,
that.
yeah.
So just letting them know that I think is helpful.
Yeah, healthy mom and healthy baby.
Exactly.
Is usually what I tell moms, even if they need a C-section, because oftentimes moms come in and say, I want a vaginal delivery. I'm like, great, we know vaginal deliveries are safer, right? But, complications in labor happens. And when those complications arise, I say, listen, I know the C-section is not what you were, you wanted. That was not what you envisioned. But at the end of the day, when you leave this hospital, it's about having a healthy mom and a healthy baby, no matter the route we go about that.
Yeah.
And once you tell people that, hey, we're on the same side, people are usually a little bit more receptive of that.
Yeah, I completely agree. Yeah. Thank you both for the insight to our viewers. So lastly, we just wanted to touch on egg freezing. That was a big topic that a lot of our viewers wanted more insight on. So I guess we'll start with, how exactly does it work?
Yeah. So egg freezing is a very involved process, I will say. But typically it involves first starting out with oocyte retrievals, which is a procedure that is done typically at an outpatient center under sedation. And in that procedure, the provider is actually removing follicles or eggs from the ovaries. And prior to that, it requires extra hormones that must be given to allow your body to make more follicles. Right? And so once those follicles are and those eggs are created, we go in and do a retrieval process, which takes about 30 minutes, 45 minutes to do, depending on how many follicles we see on the ovary. And then after that, we freeze those eggs, right? And you can either have like oocyte freezing, where it's just your eggs, or you can have them fertilized, so embryo freezing. Those are two routes for you. But it's all up to like the family, the patient, and what their desires are. And then when that patient is ready to use those eggs, whether it's with a sperm donor or a partner, it's available for them.
So can you tell us a little bit more about, like, is the cost of this? Do we know, like, the cost? Like, how much is it? And, like, at what age should women start to think about that?
So the cost varies, and it varies on what clinic you actually go to. And, the good thing about at least the two clinics I'm aware of, which would be clinic on the outskirts of Baltimore, and ours, that there's a financial counselor. You must meet with a financial counselor before starting this process, because it can be upwards of $20,000.
$20,000? Wow.
Yep.
Wow.
It can be pretty expensive. And that can be prohibitive for some patients, right?
Yeah.
To be quite frankly, it's prohibitive for me in this moment. You know what I mean?
$20,000.
Yep. So it's quite expensive, which is why you must meet with someone before starting that process. And I think egg freezing is really based on like the woman and what she wants, right? And someone will say, "Oh, at age 35, I'm gonna start freezing my eggs," as if 35. It is somewhat of a magic number, because we know your infertility starts to decline after 35. But I think it depends on if they have a partner, are they where they are in in their career, what their goals are, how many children do they want. Those are all things to consider. And to be honest, I've thought about freezing my eggs. Even though now I have one kid, it is something that I'm thinking about in the near future.
Question. So let's say someone pays $20,000 to go through this process. Is it guaranteed?
Nope.
Okay. Can you tell us more about that?
Yeah, there's no guarantee, because if you have like a frozen embryo transfer, because after they freeze your eggs, then they fertilize the egg, whether donor sperm or your partner's sperm, and then they do an embryo transfer. So after they do the fertilization process, usually we call it like a 5-day embryo, a 5-day blastocyte, right? And then that is placed back into the uterus. It's not a guarantee that that embryo is going to stick. We place them, and we have them come back in a couple of weeks and do an ultrasound or do a pregnancy test. And sometimes there's a baby in there, sometimes there isn't. So there's no real guarantee to it.
So it's a gamble, essentially.
Somewhat it is a gamble. The good thing, I will say, if that's a route that a patient chooses, is that they can have genetic testing done on that embryo. So a couple of cells can be taken out, sent out to an outside company to see if there are any abnormalities. If that oocyte is not appropriate, meaning that it may have a trisomy, then they will exclude that particular egg. So the goal is to only implant healthy eggs, essentially, or healthy embryos. So that increases your outcome some, but again, there's no guarantee.
Are there like side effects though of the freezing process? For the woman, for the mother.
But we have to give hormones to put your body into almost not necessarily a pregnancy-like state, but to make sure the lining of the uterus is thick and right for implantation. And sometimes that can cause women to have very sharp pain. You know, in the ovaries because they have like extra follicles because we've hyperstimulated them in some ways. But the process itself, you know, we talk about the risk of like bleeding, infection, just like with any other procedure, but it's not really an increased risk for the egg freezing itself.
Got it. That makes a lot of sense.
Yeah, well, thank you.
Yes.
Time flies so quickly when
does.
we start sitting down and chatting.
Especially when it's such an interesting topic.
Yeah.
Yes.
But our question that we ask all our guests is, for a medical student who wants to go into OB-GYN, what's one piece of advice that you would give them?
Oh, wow, that's really good. One piece of advice I would give would be to really find someone in the field that you can like mentor, who can mentor you, and know like what it is that you love about OB-GYN, right? Because some people say, well, I want to do women's health. And I'm like, well, as a primary care provider, that's still women's health.
Yeah.
Like women's health is not just involving OB-GYN, right? But figure out your why. And I tell people this with anything that they do, but figure out your why and, you know, find someone who can mentor you and, you know, start working early to get there. There are so many good programs around the country. And if you want to be OB-GYN, do you want to be a generalist? Or you want to do obstetrics and gynecology? Do you only want to do gynecology? Do you want to do OB? Like there's so many subspecialties within our field. And I would say look into all of those. What best fits you.
Awesome.
That's perfect.
Thank you so much.
Thank you so much for coming in today, too. This was a great conversation.
I know.
So
I
good.
feel like our viewers will really get a lot out of this.
Yes.
Remember to follow us on TikTok at We'll Keep It Short, and our YouTube is at We'll Keep It Short as well.
Thank you guys for watching, and thank you so much for being here, Khadijah.
Thank you for having me.
Of course. Thank you.
Bye-bye.